Hello, everyone, and welcome to Conversations in Interventional Cardiology. My name is Sandeep Nathan. I'm a professor of medicine and an interventional cardiologist at the University of Chicago Medicine. I'm also an associate editor for JSCAI, and I'm absolutely honored to represent SCAI and the JSCAI editor-in-chief, Dr. Alexandra Lansky, for this conversation in interventional cardiology. We're here today to discuss an important SCAI consensus document that was recently published in JSCAI titled SCAI Expert Consensus Statement on Alternative Access for Transcatheter Aortic Valve Replacement. And I'm joined by an esteemed panel of leaders and experts in the field, Dr. Matthew Sherwood, Assistant Director of Interventional Cardiology and Director of the Structural Heart Disease Program at Inova Fairfax. Welcome, Matt. Dr. Kendra Grubb, Vice President and Chief Medical Officer of Structural Heart for Medtronic. Welcome, Kendra. Dr. Adam Greenbaum, Co-Director of Structural Heart and Valve Center at Emory. Welcome, Adam. So thank you all for taking the time to join us and to walk through this very important document. Matt, I'm going to turn it over to you if you want to get us started with some slides.
Thank you so much. And honestly, I want to say it's a pleasure being here on behalf of this tremendous writing group. I can speak on behalf of myself and Dr. Mahoney, my co-chair, to say it was a privilege to work with them in developing this document. We set out to provide a document that would review existing evidence and hopefully provide guidance for best practices around alternative access for transcatheter aortic valve replacement. To that end, the document is comprised of the following sections. First, we looked at current frequency and trends of the use of alternative access routes for TAVR, as well as any technological advancements. We then provided a brief synopsis of each potential alternative access technique and described best practices. We sought to reference detailed step-by-step documents where they existed and not to rehash all of those. But we did provide consensus recommendations where we felt it was appropriate based on the best available evidence. We also reviewed data on clinical outcomes and post-procedural care that might be unique to each technique. And finally, we wanted to highlight the role of proctoring in learning some of these new techniques and look at future directions for where evidence might go. First, I want to acknowledge that alternative access for TAVR is certainly the minority of cases in the United States and probably in the world. However, this is important because these patients tend to have more vascular disease, more medical comorbidities, and are overall a sicker population than patients who have transfemoral access TAVR. Most recent data suggests that it's a little less than 5% of patients who undergo TAVR require non-transfemoral access. So we wanted to present trend data. And here we can see two charts that look at the two most common TAVR systems used in the United States, the SAPIEN as well as the Evolut. The two charts basically tell the same story, and that is from 2015 to 2023, we can see there is a significant and consistent decline in intrathoracic access, that is transapical or direct aortic access, as well as over the last 5 years, a decline in the use of transaxillary or subclavian access. In that same period of time, we've seen a significant increase in transcarotid access and a more modest increase in transcaval for alternative access. Throughout the text and in charts and figures, we wanted to provide both quantitative and qualitative data comparison to give clinicians a way to compare and contrast the most frequently used extrathoracic alternative access techniques. And so here's an example of one of the tables. I won't go through all of these results, but we can see that, for example, mortality is similar between these techniques, but there may be slightly greater stroke risk associated with transaxillary access versus transcarotid or transcaval. On the other hand, both transaxillary and transcaval could be done completely percutaneously, whereas transcarotid requires surgical cut down and general anesthesia. All of these statements were crafted by the group as a whole, and I will say that they were voted upon, and it required 75% of the group to basically make it a consensus statement. Many of the statements that we made were unanimously supported, but some were more controversial. So, obviously, the evaluation of access and some of the other statements were unanimously supported. But I will say, for example, statements about the axillary subclavian approach, that is that they might be associated with higher risk of neurologic complications, was a little more controversial in our group. And finally, comparison of non-transfemoral access approaches, as I mentioned, we thought that where feasible, transcarotid or transcaval access might provide better neurologic outcomes than transaxillary access. But, more of a unanimously supported statement was that extrathoracic access, whether it be transcarotid, transcaval, or transaxillary, should be preferred over intrathoracic access, such as transapical, where at all possible. More importantly, really the role of proctoring this is really, really important. As many TAVR sites come up, the use of these techniques will be in a very small minority of their cases, and thus they should really focus on learning one or two techniques and sticking with those. In addition, if they are not prepared or experienced enough in a technique that a patient needs, they should consider transferring that patient to a larger center that has that skill. And physician proctoring is really, really important for gaining these skills. We did basically reference a recent SCAI statement on physician proctoring as well. The final thing I'll say is all of this is based on the currently available evidence, and there are no randomized clinical trials that look at comparing these techniques. Very little overall evidence in the space other than observational data. But I will say we would like to see more and more evidence looking at possibly the use of augmented femoral access, because that seems to be a growing kind of technique used amongst these patients. And we don't have a lot of evidence that supports its use, but it could be a lot easier for many centers to use augmented transfemoral access with shockwave or other technologies than learn one of the more complicated alternative access approach. So with that, I'll wrap up.
Okay, great. Thank you for that terrific overview. And now I think we'll just open it up to conversation. This is an important document that I think we could probably talk about for an hour because there's so much nuance to this. I'll throw the first question out, Matt, and please, everyone, just feel free to weigh in on this. What do you think is the most important takeaways for the community of TAVR operators? And so it's sort of a mixed bag right now, right? You've got TAVR operators like myself that trained, just on the job, 12, 13 years ago at the dawn of TAVR, at least a commercial application of TAVR in the United States. And then you've got folks going through structured, fellowship programs. As this sort of shifts a little bit, what do you think is the most important takeaways if you're practicing in, let's say, a mid-volume TAVR center, which is, I think, the majority of them?
Yeah, I think it's really, really important to rely on the multidisciplinary team, and that includes not only interventional cardiologists and surgeons, but also vascular specialists. So endovascular specialists who can help you with understanding how difficult some of the access questions will be. And then I think it's important to recognize your limitations. At any center, you'll have more experience in this small minority of cases that you're doing non-transfemoral, and you should recognize where you have the skills in one specific kind of technique. For example, at our center, we're a very large center, but we mostly do transcarotid technique. And so if the patient does not have the feasibility for that technique and you don't have the requisite skill, then you should really consider transfer to another center, or you should consider proctoring to gain that skill to provide that to the patient. But I think that's really important for any size site to recognize your limitations.
Kendra or Adam, would you add to that?
I think, yeah, I mean, what his final comments were is really important that we keep in mind that you're not going to see alternative access cases that frequently. We talk about 5% of cases are going to need alternative access. And as Matt alluded to, some of these patients are going to be able to have shockwave or other therapies that will make them be transfemoral candidates. And so if you're only going to see a handful of cases a year, you really only need one procedure that you're going to be very good at, one alternative access. And if you're Adam Greenbaum, that's going to be transcaval, but that may not be every site. And so have that one that you can do well, and then be realistic and maybe send those other ones out. And so whether that's transcarotid as your alternative access of choice or whatever that is, get really good at that one.
Yeah, thank you for that. I think that's a perfect segue to a question for Dr. Greenbaum. You've done such tremendous work in this space. What does transcable look like at your institution? How do you sort of decide having the skills and the resources to do all of it?
Sure. So that's right. We feel comfortable with transcable, of course, as well as, transcarotid is probably our second choice for alternative access. And, for us, the reason for transcable over transcarotid is mainly one, because to us, it's just the most cath lab-like. It just doesn't change the sequence of events for us. The cath lab staff would really not even care whether it was transfemoral or transcable. The patient's draped the same way, or the shielding's the same way. We're not moving the image intensifier to one side or the other. We're not changing any of the monitors. So, we have the flexibility to just go back and forth, and it doesn't really change our workflow. That being said, that the centers that do transcarotid and transaxillary much more frequently, well, it's in their workflow, right? So when they say it's a transcarotid, everyone knows, move the monitors, So I think it's not necessarily that's why you should do transcable, but that's what it is for us. But the other interesting thing is I've never really seen a great article or any great manuscript that said, of people that require alternative access, how many of those three would they be a candidate for? Has anybody ever seen that analysis done? Because my guess is, to piggyback on what Kendra said, you're right. We're not going to see that many of them in general. And if every one of them was a candidate for all three, then maybe you do only need to pick yours and get really good at it and be comfortable with it. But I'm not sure everybody's a candidate for all three. So then what do we do? And I do think that transferring to a center that knows how to do the other one is probably the way to go, right?
Well, I was hoping that Amir would join us, but please feel free to weigh in here. I think that PERC-ACS seems for most folks to be a very accessible and cath lab based procedure. If you have experience with large bore and you have experience with covered stents, you should be able to get this done. Maybe you guys can talk a little bit about the learning curve associated with PERC-ACS. Obviously, a high degree of planning and imaging and skills for transcable. Can you weigh in a little bit here on PERC-ACS and maybe also the stroke risk, because this is a controversial area.
Well, I can comment a little bit. When we go all the way back to the original studies and the larger sheaths, I mean, you go back far enough and you're talking about, intrathoracic, and you're doing transapical and even, mini sternotomies and transaortic. You think about, early days of TAVR. Well, the alternative access for the Medtronic valves were actually transaxillary and with a cut down. And as we evolved, we were able to do PERC-ACS. But one of the Achilles heels of that therapy has always been the stroke risk. And, we say somewhere 5 to 7%, depending on the series, but that's significantly higher than transfemoral. And I think that the patients now expect something around the national average, which has hovered 2 to 3%. It's gone lower as we've gotten into younger patients. And I believe, Adam, please correct me if I'm wrong, but I think in the series you published, you combined stroke and TIA, and it was over 10%, almost 13% or something, right? And so, I mean, that's a really high rate of stroke. Now, that wasn't a clean series of just PERC-ACS, but, I would be really concerned if that's what I was offering patients. Adam, you want to comment?
Sure. I mean, I think the majority of the safety data on Transact probably came from circulatory support, right? Basically Impella, and it's not as big a sheath, right? So I think, whether, you can extrapolate that to the safety of TAVR is uncertain. But for the centers that do it and are comfortable with it, I think it's a reasonable alternative also. One thing that's interesting to me, though, is the consensus statement, of course, says that proctorship is important, right? And actually, people ask me all the time, how many cases does it take to learn transcable? And it's the same 2 to 3, to be honest with you. But interestingly, access to proctorship is not the same, right? Because you can call Medtronic, and you can call Edwards and you could say, hey, I've never done a transcarotid. Can you send someone to help me? And they will. And I suspect they would for TransX too, but you can't right now for transcable. So your access to proctorship actually is limited, right? So when you look at some of the data on the trends and how much is being done, you know, you kind of have to factor that in as well.
Yeah, I think those are all great points. Let's pivot now and talk maybe briefly about facilitated or augmented femoral access. I mean, this seems sort of the most freely available for operators, and it's not quite a data-free zone, but there's a paucity of good data on this. For JSCAI and for other journals I've reviewed for, I've seen small series, but compared to the number of cases that are probably being done, it just seems like a drop in the bucket. And the other thing I'll sort of add to that, because we are very much in the augmented femoral camp at our institution, when we actually take meticulous cuts through straight segments with IVUS, we typically find a lot of additional information. Myself and Giorgio Medranda, as you know, had the privilege of authoring a brief editorial to accompany this paper. And, frequently these IVUS measurements tell you something substantially different than the CT measurements, rendering a small proportion of patients perhaps approachable from a facilitated or augmented femoral approach. So maybe talk a little bit about that, just weigh in here as to, why we don't have more data on this and, how does that play in your practices?
Well, I would just mention, obviously, as you said, it's much more available to interventional cardiologists and feels much more comfortable in terms of their skill set. So they feel very comfortable typically doing an intervention on the femoral or iliac artery. And so for that reason, I don't think it drives people to look at it in a systematic way. I do think that would be very, very important for this area. We all know that the device delivery systems are getting smaller and they're getting easier to use. So the necessity for augmented access or alternative access is declining. But the overall number of patients that we're doing is still increasing. And so I think it's very, very important to have these skills for the minority of patients that we do. But, I think it's honestly a call to all of us to try to systematize how we collect data for augmented femoral access, because I think that could be one of the most important and widespread use of technology for providing more patients transfemoral TAVR.
Well, I think we're almost at time. I think that's a fantastic note to end on. So I will thank all of you for the document and for participating in this conversation in interventional cardiology. Thank you for everyone who's listening.